Hello and welcome to the workshop, Oral Health After Treatment, Navigating Graft-versus-Host Disease, Medications and Infections. My name is Penina Seidman, and I will be your moderator for this workshop. Before we begin, I'd like to thank Incyte, whose support helped make this workshop possible. It is my great pleasure to introduce today's speaker, Dr. Jacqueline Mays. Dr. Mays heads the Oral Immunology Unit within the Division of Intramural Research at the National Institute of Dental and Craniofacial Research at the National Institutes of Health. She is an immunologist and a clinical trials dentist whose research focuses on chronic GVHD and the salivary glands and oral mucosa. Please join me in welcoming Dr. Mays.
Thank you so much, Penina, and thank you to you and Sue and Marla, who have done such a phenomenal job putting this symposium together. So it's a real privilege to be able to speak with you all today. Thank you to everybody who's logged in and to everybody who will watch the recording of this session. I sincerely hope that it is useful for you. I plan today to tell you about general oral care after transplant, things that can happen in your mouth, so in the oral cavity following transplant, what chronic graft-versus-host disease looks like in the mouth, different forms that it can take, and also treatments that we commonly use and less commonly use for the treatment of oral graft-versus-host disease. Importantly, and the number one principle that we'll talk about today is taking care of your mouth. We'll discuss how to establish community dental care, so the who, the what, and the when. We'll talk about oral cancer screenings, which are particularly critical after transplant. We'll talk about non-GVHD post-transplant complications, so things that can happen in your mouth following your transplant that are not chronic graft-versus-host disease. And then finally, we'll spend some time talking about graft-versus-host disease in your mouth. So what it feels like, what it looks like, and the available treatments. So the oral cavity is the gateway to the body. It's really a tremendous environment that serves as the portal that you use to eat, to speak, and to some extent to breathe also. So it includes all of this mucosal tissue that covers the surface. So this is a type of epithelium just like your skin, but it's obviously specialized because it's on the inside of your mouth. It is wet. It has local biofluid that we call saliva. It has its own microbiome, so there are unique populations of bacteria in your oral cavity. And then we have immune tissues that are plentiful within the oral cavity. So your tonsils are right at the back of your throat, sort of at the entrance to that pharynx. And then you're able to generate a wonderful immune response underneath your tongue in that sublingual space where the epithelium is very, very thin. On a daily basis, one of the most important things you can do is to simply take care of your mouth. When we talk about brushing, we talk about using toothpaste with fluoride in it or with one of the more advanced calcium compounds. This fluoride acts as essentially a vitamin to support your dental enamel. So if the enamel has broken down a little bit because of acid that's being produced by the bacteria, in your mouth, this fluoride is able to replace the calcium in the enamel structure and sort of re-harden the enamel. So it kind of comes in as a cleanup crew. If you have a sensitive mouth after transplant, whether or not you have graft-versus-host disease, there is now a plethora of fruit-flavored toothpaste. We always used to recommend children's toothpaste. The only problem with children's toothpaste is it has a little bit less fluoride in it. So now I like to recommend one of the many, many fruit-flavored toothpastes that don't involve mint at all. If you walk into your local CVS or Walgreens or wherever you buy your toothpaste, you'll find half an aisle full of different non-mint flavors of toothpaste. Excuse me. If you have sensitive teeth, it's highly recommended on a regular basis that you're getting some extra support from extra fluoride. What does this look like? This can look like fluoride rinse or gel. It can look like that you would get from your dentist as a prescription. It can look like desensitizing toothpaste. Some of these are over the counter, including Sensodyne, Pronamel, and Colgate Sensitive. And there are also professional desensitizing treatments that are available in the dental office. So these are things that you would want to ask your community dentist about. I always recommend to our post-transplant patients, whether or not you have limited joint mobility, but particularly if you have limited joint mobility, in the setting of graft-versus-host disease or any other challenges, that you use an electric toothbrush. So this can be any type of electric toothbrush from the drugstore. One of the favorite things I like to say is that the more expensive your toothbrush is, the quieter it is, but it really doesn't make it any more effective. So the toothbrush shown on this slide is a $20 or $30 model that you can get from Amazon, and it simply vibrates, and this helps to really sort of power the plaque off of your teeth and keep them a little bit cleaner. So it multiplies your effort in brushing your teeth. In addition to taking care of your mouth, includes flossing. So this is a great way to get the plaque and the food out from between your teeth. Sometimes, especially if patients have been on prednisone, your gums will shrink back a little bit, and then that enables food to get caught more frequently between your teeth. So cleaning between your teeth becomes a lot more sensitive. So using traditional floss, I don't know if you can see this on the video or not, I like to take a big piece, a nice long piece, wrap it around my middle fingers, and then you can use sort of your pointer fingers and your thumb to manipulate that between your teeth. We know that this is not the easiest technique to master, especially not if you have other challenges or mobility issues. I strongly encourage the use of floss picks or any other aid that's shown on this slide to help you clean between your teeth. There's something called a water pick or other type of electric flosser that will shoot a little stream of water, or you can also use an antibacterial mouth rinse. You fill the device with whatever you would like to use with it. And this is sort of like it's like a power wash for between your teeth. So these can be very helpful for getting the food and the bacteria out from between your teeth. And of course, we recommend seeing your dentist on a regular basis. Following your transplant, as soon as you're cleared by your medical team for regular dental care, it's recommended that you return to your every 6-month schedule for regular cleanings and checkups, primarily because problems that are small are much easier to fix than problems that have been ongoing unchecked for several years. Okay, so how do you find community dental care, aka a dentist? You probably had a dentist before transplant. Hopefully you saw a dentist right before your transplant. That might have been at your cancer center. That might have been somewhere else. It might have not been where you get your regular care. But I always recommend that you tell your dentist you're a transplant survivor, that you show your dentist anything unusual or new that you see or feel in your mouth. In general, mouth ulcers, lumps, or bumps should heal within 3 weeks. That's sort of our general rule of thumb. Anything that lasts a little bit longer probably needs to be checked out. And I also strongly recommend every 6 months when you're in, do ask for an oral cancer screening. This a lot of times is something that the dentist might tell you she or he is doing, but oftentimes it's when they take that piece of gauze, they wrap it around your tongue, and they sort of move everything all around so that they can see into all of the nooks and crannies in your mouth. And I've got asterisks down here reminding me to say that if you have GVHD in your mouth, that is not expected to heal within 3 weeks, unfortunately. A couple more notes. Next slide, please. On finding community dental care or a dentist. Not every dentist will appreciate your complex medical history and needs. If your dentist is not a good fit, feel free, or please interview other dental offices, talk to the staff, find out who is good at sort of seeing patients as a whole and taking the time that's needed to treat patients who might have a little bit more complex medical history than your standard, every 6-month cleaning in an adult. You can always ask, do you have experience treating medically complex patients? That's sort of like what the lingo is in the dental world. A good place to look is always the universities. So if there are dental school faculty or resident practices that you can go to for your regular care in the area, or clinics that are at a medical center are also a good option, because these are hospital dentists and these are academic dentists who are used to seeing, transplant is quite common, but it's less common in the community than it is in a university setting. And then I strongly encourage you to get at least an annual oral cancer screening. This is not something that I want you to stay awake at night worrying about. We know that after transplant, patients have a higher risk of oral cancers. This is not, it's still a very, very small risk. The highest risk is in patients who have had a significant oral GVHD history. So you've had a lot of inflammation in your mouth for a long time. And we typically start seeing these 5 to 10 years post-transplant. So these are typically oral squamous cell carcinomas. A lot of times we'll find them on the tongue. This picture is one of my patients who presented at 5 years post-transplant with a new oral squamous cell carcinoma. He had noticed it 2 to 3 weeks prior to the coming in to see us at the NIH. I suspect it had probably been there for a lot longer. But it's difficult to always, notice new things that are in your mouth. These are often painful. So that is one thing that will often differentiate these types of lesions from something else in your oral cavity. Okay. Thinking about the timing of post-transplant complications, this is something that's always helpful to know when to expect some of these things, or maybe when to watch out for some of these things. I hesitate to say expect because they are not going to, occur in every patient, and they're becoming more and more rare as we advance our own expertise in the world of transplant care patients. So in the early days post-transplant, so in that first 100-day post-transplant period, what we will often see in the oral cavity is mucositis. We will see patients reporting dry mouth, and this can be from a number of things. And then we see patients who develop oral thrush. So this is candidiasis. We always have a little bit of yeast in our mouth. This the most common strain is Candida albicans. And when you're immunosuppressed, that yeast can overgrow. So that is what we call thrush. In the overlap period, we start to see drug-induced complications. So sometimes this is because of challenges with dosing methotrexate and sirolimus. Sometimes we start to see viral infections breaking through, again, because patients are immunosuppressed. This includes herpes simplex virus and human papillomavirus. And then in the later stages, so here, we need like a little approximately sign because this is approximately 100 days post-transplant or later. That's when we start to see signs of chronic graft-versus-host-disease. So this can include dry mouth, oral ulcers, white lacy lesions. We'll talk about these in more detail a little bit later in the slides. And then much, much later, so years, as we mentioned, we most commonly see these secondary cancers 5 to 10 years post-transplant. Non-GVHD post-transplant complications can include loss or change in taste. So the way that your food tastes, a lot of times this changes because of your pre-transplant chemotherapy, and it's something that gets better over time. So every month we typically see improvements in this, we call it dysgeusia, but the change in taste. You can experience radiation-induced dry mouth. If you did have pre-transplant irradiation or radiation at some point during your cancer therapy. We also see medication-related oral ulcers or lesions. I've got some pictures of these a little bit later. So sometimes we do a biopsy to differentiate these from graft-versus-host disease, and sometimes based on your medical history, it's pretty straightforward to diagnose what's going on with those lesions. And of course, there are the infections. So there's thrush. Sometimes we'll see a superficial bacterial infection in your mouth or viral infections. Just like the rest of your body, during an immunosuppressed state, you're more susceptible to infections that your body in a normal, healthy state would fight off. And here I've included cold sores as its own line because this is, of course, a viral infection. But we do see it quite often after transplant, especially if patients are on high-dose prednisone or another steroid, where we see this sort of recrudescence of the herpes simplex virus. Unfortunately, it never really goes away. It lives dormant in your trigeminal ganglia, right by sort of your jaw joints. And this can come back if you're in an immunosuppressed state. Okay, so how do we treat mucositis? Next slide, please. Great. And this is something that can happen early post-transplant. It may be something that you experienced prior to your transplant during chemotherapy. So oftentimes we'll administer something called cryotherapy. So this is, they have some different formats. The most simple one is simply sucking on ice chips. There are medications that are really super saturated calcium phosphate rinses. So these are very thick and they help to soothe the tissues and reduce the inflammation. There are adherent mucosal barriers. So this is kind of like, it's almost like a jello that will coat the inside of your mouth and help protect that very, very fragile mucosal tissue from being disrupted by your tongue. It will help you be able to eat a little bit easier. Pain control is really important in mucositis. Again, we want you to be able to eat because getting that nutrition into your body is really critical for being able to heal. And then a newer therapy that's being used at many centers is red light therapy. This is also called photobiomodulation. It's administered with different protocols, but basically it's a very intense red light. The wavelengths differ a little bit too. It's usually between 660 and 860 nanometers. But this is administered a few times a week, and it helps to reduce the inflammation in your oral cavity and promote healing. Moving on to some of the photos of what some of these things look like. This is a picture of very early recurrence of herpes simplex virus. So this type of reactivation is very common. You can see on this patient's, the corner of the lip, there are active vesicles. This is something that you'll see very early. Oftentimes we see them after they've already popped because they are quite fragile. And these ulcers are exquisitely painful. So they tend to be very small. And you can see an image on the inside of this lip of some of these vesicles after they've popped. But we often suspect HSV if the vesicles are very, very painful. To diagnose this, we can swab. So just, take a little Q-tip and send it to the lab to look for the DNA from that virus. This is managed using systemic antiviral treatments and also lidobenalox, which is a numbing agent and sort of a soothing agent. It's a mouthwash that's mixed up by your pharmacy to sort of soothe that area and allow you to get good nutrition. We've got some images of oral thrush or candidiasis overgrowth. This can occur as a pseudomembranous or an erythematous form. Not something that you need to know, but do know that it can look like sort of white stuck-on material in your mouth. On the rightmost side of the slide, we see it on a tongue. The erythematous form is here in the middle tongue, and then sort of something that has gotten within that tissue is shown at the back of the throat on the rightmost side of the slide. Typically, if this is the white stuck-on appearing kind, it will wipe off with a piece of gauze. The classic sign that this is candidiasis and not something else is that the tongue will burn. It'll feel, like burning, especially if you drink, a sip of water, something that normally would not irritate your oral cavity at all. And then this is managed using topical antifungals. So oftentimes an antifungal medication that you melt on your tongue, and potentially also your systemic antifungal medication. Great. Something else that we commonly see, this is medication-induced for patients that are on sirolimus or another mTOR inhibitor. That's the same class of medication. You can develop some oral ulcers or less commonly an oral stomatitis that's really like everything sort of reacting. But because of excess circulating levels of these drugs, including sirolimus, you can develop painful aphthous-like ulcers. So this is, these oftentimes look a little bit like a cold sore. They have well-demarcated borders, and there are white arrows in each of these pictures that are pointing to the ulcers. We recommend for treatment of these topical steroids, again, that magic mouthwash, that lidobenalox, and most importantly, adjustment of the sirolimus dose. So if the sirolimus dose is not adjusted so that the blood levels are within therapeutic levels, and this would be done by your medical team, then those ulcers will continue to be there. Moving on to what graft-versus-host disease looks like in the oral cavity. Oftentimes, this will begin as dry mouth or temporary blisters on the roof of the mouth. You might have heard these called mucositis. So they're like little blisters that you can feel with your tongue on that roof of your mouth, and sometimes on your lower lip also. Patients can develop red or white patches in your mouth that you can't scrape away. So that candidiasis that we talked about, you can often scrape that away or wipe it away with a piece of gauze. With these hyperkeratotic patches, these white patches from GVHD can't be wiped away with a piece of gauze. Mouth ulcers are often not the first thing that you experience with graft-versus-host disease, but they certainly are something that is part of the disease course. One of the earliest signs will often be these white lines on the cheek lining or other mucosa. So if you look, it'll sort of look like white lacy lines on the inside of your cheek. Sometimes this can be on your lips, which is a little bit easier to see than all the way in the back of your mouth, but they're often there. And then one of the first symptoms that, along with the dry mouth, that people tend to experience is this oral sensitivity to spicy foods, citrus flavors, acidic foods, things like tomato sauce. So things that would have never bothered you in your pre-transplant life will suddenly be too painful to put in your mouth, or at least, highly irritating to put in your mouth. So this is what oral GVHD looks like in the mouth. And these are slides showing sort of a mild or moderate presentation, and then a moderate to severe presentation. And the photos go through all of the different parts of the oral cavity. So the hard palate or the roof of the mouth is up on the upper left-hand side. The inside of the cheeks or the buccal mucosa is the next set of photos. And here you can see, unfortunately, well, you can see these white lacy lesions, these lichenoid-pattern lesions that we were talking about. But then sometimes these will progress to be, pretty big ulcers on the inside of your cheek. Oftentimes these aren't painful, simply because of the way the GVHD progresses, but they can be quite big, and they're obviously very, very sensitive if they're poked either with your tongue or with food while you're eating. And then moving down, we've got different ways that the gingiva can look. A lot of times it just looks very, very red, but sometimes we do see that the gingiva will sort of turn white. So these are your gums. Less often we see that there are ulcerations, but we can see that that's possible. And then moving over to the other side, there are many different ways that tongues can look if your tongue is affected. So sometimes we see some building up of this white tissue, this hyperkeratosis. And then again, on the lips, we can see these white lacy lesions, and sometimes we'll see ulcerations on the external lips as well. We often think about GVHD, oral GVHD, as three distinct diseases. So this includes the oral mucosal disease, which I just showed you detailed photos of, salivary gland dysfunction, or very dry mouth because your salivary glands, which make your saliva, are no longer working, and then limited mouth opening. And limited mouth opening, a lot of times, is not because of anything that's happening actually inside your mouth. Rather, it's because the skin on the outside of your mouth, or sometimes less often your temporomandibular joints that are sort of that hinge jaw joint, are being affected by the graft-versus-host disease. And those are sort of tightening up and limiting the amount that your mouth can open. These manifestations need different treatments. The underlying pathology is different, and the prognosis is different for them as well. Okay, so moving on to diagnostic criteria. This is the criteria that your doctor will use to diagnose graft-versus-host disease in your mouth. So if they see those white lacy changes in the mouth, that is a definite oral GVHD diagnosis. In general, the presence, or if they don't see those, but there's at least one distinctive manifestation that's either confirmed by the biopsy or other relevant tests to rule out any of these other things that could be causing changes in your mouth. So these include dry mouth, they include blisters or fluid-filled lumps on your inner cheek, lips, or floor of the mouth. They include loss or shrinkage of normal tissue, so things kind of shrinking away and looking a little bit different. They include white patches on your mouth, and that can be anywhere on your mucosa, so that lining of your mouth. And then the things that we generally want to exclude before we call something GVHD include infections in the mouth, drug reactions, or new cancers. So once those things have been excluded, generally treatment for graft-versus-host disease can be started. Okay, so what do these diagnostic features look like? This is a closer view of these lichenoid lesions, these white lacy lesions. To the left is a view on the inside of the cheek. And then on the right-hand side on the top, this is a view of an upper lip and how these look. And then there's a much more subtle view of the inside of the cheek. So this is a little bit harder to see. And if you're at home looking in your mirror, this is something that would be a little bit more challenging for you to see in your own oral cavity. So oftentimes we see changes in the roof of the mouth, here the hard palate. We can see this sort of like white hyperkeratosis because your epithelium just kind of grows a little bit extra and makes sort of a thick white covering. We see these mucoseals, and if you look closely on the right-hand side top photo, you can see these little blisters. So these happen because there's inflammation in your tissues that then pinches off the opening for your minor salivary glands that are in the roof of your mouth. And then the saliva that they're making that's supposed to be making your mouth feel nice and moist isn't able to get into the oral cavity. So that is stuck. So these mucoseals are full of saliva. However, if you pop the mucoseals, they can easily get a secondary bacterial infection. So I recommend leaving them alone. They are irritating, but they sort of wax and wane. When you're thinking about food or eating, oftentimes these mucoseals pop up because your mouth is trying to make saliva, but they will go away and sort of come down in size within an hour or two. And then the other picture of the palate is simply showing erythema, so redness and sort of an irritated looking roof of the mouth. Okay, clicking over to the next slide, looking at different tongues in GVHD. Oftentimes when we see atrophy of the tongue or shrinking away of that tissue, you can have loss of your taste buds. So on a normal tongue, there's often like almost a furry appearance. So you've got sort of that rough texture on your tongue. And with graft-versus-host disease, a lot of times we see a smoothing away of those taste buds. And we call that atrophic glossitis. We can also see, again, this patchy hyperkeratosis. So in this middle photo, it's really like patchy shrinkage of those taste buds on the tongue combined with white patches showing up on the tongue. And then less common, but we do see this patchy tufted hyperkeratosis on the dorsal tongue, where the taste buds essentially are just growing unchecked, the epithelium on them and making sort of these fluffy white things. This looks like candidiasis, does not wipe away, so does not need to be treated like thrush. Looking at different types of ulcerations, one of the things that I always like to do when I'm seeing my post-transplant patients is ask if anything in your mouth hurts. Some of these ulcers can be quite small or very hidden. If you look at this first picture on the left-hand side, this is a pseudomembranous ulceration that was under this patient's tongue. And sometimes these can hide from us if we're not looking really carefully. But if it's in your mouth, you will probably know that it's there because these will hurt if anything is bumping against them. Ulcers like this one on the right top on the lip are very easy to see. You'll also know that that is there. I want to stress that graft-versus-host disease is not an infectious disease. So it's not like having an HSV, like a herpes ulcer on your lip. So this is not something that you can, give to somebody else. You can't infect somebody else with graft-versus-host disease, even if you have lesions in your mouth. And then much more subtle is this little bump underneath this picture with another ulceration. And this is one that was very hidden between the lip and the teeth. Okay. Moving on, we talked a little bit about salivary gland graft-versus-host disease. This is something that's a little bit more challenging to diagnose with mucosal GVHD in the mouth. It's very easy to see. We can, if you open your mouth, you can see, we can see, and we sort of know what's going on. But if GVHD is affecting your salivary glands, so the structures that are producing the saliva in your mouth, we will ask you, is your mouth suddenly drier? Is your mouth progressively drier? Like, did that dryness happen right away? Or has it been happening over time? Can you chew and swallow food without drinking water? Are you taking medications that cause dry mouth? Many different types of medications can cause dry mouth as a side effect. And then also, did you have a radiation? So either total body radiation or radiation that was targeted to the head and the neck as part of your cancer therapy or your transplant preparation, because we know that the salivary glands are one of those very sensitive tissues to radiation, and this can have a longer lasting impact. I think one of the things I forgot to mention, if we definitively want to know if there is GVHD in your salivary glands, one of the things we will do is to take a biopsy. A local biopsy from your lower lip so that we can see if there's graft-versus-host disease under the microscope versus something that's medication-induced or radiation-induced. Okay, thinking about topical therapy for graft-versus-host disease for these mouth sores, if there are lichen planus-like changes, you'll most likely be started on a steroid rinse. The most important thing with these steroid rinses is that you keep them in your mouth for at least 2 minutes, maybe longer. You do not need to act like you're trying out for a Listerine commercial. You do need to hold that medication in your mouth for 2 to 5 minutes. You can do something else. You can watch some videos or, answer some emails from friends. But you want to hold it in your mouth for that amount of time and use a timer and then spit it out, because you want the medication to have time to actually get into your tissues. Something else that can be used are these calcineurin inhibitor rinses or tacrolimus rinses. These are generally compounded by your pharmacy, and we often will use them in patients who can't tolerate steroid rinses or shouldn't have steroid rinses. If there are isolated oral ulcers, a lot of times we will try to use topical treatments that are just sort of like spot treatments. These can include topical steroid gels. They can include tacrolimus gel. If something just really isn't working, we can inject steroids directly at the base of those ulcers and kind of try to force them to heal. In some countries, not the United States, unfortunately, you can use autologous blood products to sort of seal these off and encourage healing. And then, of course, topical anesthetics are very important to use in conjunction with these agents. One, so that you can tolerate whatever topical treatment you are using, and two, so that you can continue to eat. So we know that we need better therapy for oral graft-versus-host disease. This keeps me awake at nighttime. There are 2 clinical trials in the United States that are currently open. Both are relatively specialized. The first one on the left-hand side of this slide is for patients who have medically induced xerostomia. So this is dry mouth. And it is placement of mesenchymal stromal cells to try and restore salivary gland function. And this is a trial that is open specifically at the University of Wisconsin-Madison. And then there is an additional trial using red light therapy to treat mucosal chronic graft-versus-host disease. And the question here is if this red light therapy can help oral chronic graft-versus-host disease. So there are sites for this study that are open in New York City and Pittsburgh, PA. There was a site at the NIH. We've recently closed this. But I know that each of these other sites still have a few slots that are open. Aids for dry mouth. What to do if your mouth is dry. I recommend either chewing or sucking on sugar-free gum or candies. So if you use full sugar candies, gums, or lozenges, this will sort of hypercharge decay in your mouth. So you want to make sure that whatever you're putting in your mouth is sugar-free, especially if you're going to be sucking on it for a long amount of time. So xylitol is an alcohol-based sugar that can also reduce tooth decay. You can look for it in your sugar-free gum or candy. And just as a note, oftentimes lemon flavors can stimulate saliva. Mint can too, but in the setting of graft-versus-host disease, oftentimes that's not a flavor that can be tolerated. We recommend frequent sips of water and staying really well hydrated. And some patients find relief from lubricating rinses such as biotin. So this is essentially like chapstick for the inside of your mouth. So it's a lubricating agent. It will work for a little bit. It might help you feel a little bit more comfortable. There's actually a whole host of dry mouth rinses on the market. Find one that works for you. And try, if you can, to get either your medical center doctors or your dentist to give you some free samples so you can try out some different brands. Okay, next slide, please. There are prescription medications that can stimulate saliva production from intact salivary glands. Two of these drugs are pilocarpine or cevimeline, trade names Salogen or Evozac. These will take a few weeks to show an effect. They only work if you still have saliva-producing cells left in your glands. So they're also not appropriate for everybody. For patients with cardiac conditions, they're definitely not recommended. So this is something to talk to your medical team about if you think that you would like to try a medication for your chronic dry mouth. Okay, and I said it before, I'll say it again. Fluoride is important. Please check your toothpaste and ensure that it does contain fluoride. Fluoride rebuilds dental enamel that has mild damage. There are some newer generation products on the market that contain something called active hydroxyapatite. So this can be abbreviated NHA or ZNHA that can also help to rebuild tooth enamel. Saliva will typically wash away food from the teeth. It buffers the acids and the bases in the mouth, and it returns calcium to damaged tooth enamel. So if you have dry mouth, that equals less saliva, and unfortunately that equals less protection from decay. So you really need to sort of bring in the big guns to help protect your teeth. Some aids for reduced mouth opening. Progressive gentle stretching can help improve or maintain mouth opening. There are some aids that you can use to help. So you can, of course, see a physical therapist who is trained in helping to support mouth opening therapy. You can also at home simply use stacked tongue depressors. So these are these wooden tongue depressors. And I wish I had a visual aid here, but I don't. And if you can fit 3 in your mouth, bite on those 3 for a couple minutes every day. See if over time you can add 4 and then 5 and then 6. So this is a nice way to sort of help maintain and increase your mouth opening. In severe cases, perioral steroid injections can be done. So this is steroid injections around the outside of your mouth to help reduce the inflammation that is sort of helping to keep your mouth closed. And of course, surgical intervention is an option. It's not one that we like to use, but it is something that's available. Next slide, please. So key points: see your dentist regularly after your transplant has stabilized for cleanings and screenings. Call your dentist if you notice any problem or change in your mouth, especially if something lasts longer than 3 weeks. I will caution you here. If you have symptoms that you think are graft-versus-host disease, don't wait 3 weeks to see if it goes away. Just call your transplant team and let them know that you've got changes in your mouth. So GVHD can start as a dry, sore mouth. Early treatment, we know, is more successful. And rinses and aids are available to make eating more comfortable. There are other infections and issues that can happen in your mouth after transplant that are not graft-versus-host disease. So many treatments are available for these issues. And then finally, take care of your mouth by brushing and flossing every day. We know that a healthy mouth is less likely to develop problems, but unfortunately, it cannot prevent every challenge. So at this point, I am happy to take questions. And I will let the moderators take the lead on this one.
Absolutely. Dr. Mays, thank you so much for an excellent presentation, and also for rolling with the punches as we had some technical issues there. So we really appreciate you so much. We have a number of excellent questions in the chat. One is around, you spoke about this earlier, but about finding the right provider for oral health. And so we have questions in the chat of, how do you know if a more community-based or small town dentist is sufficient to help you monitor for GVHD? Can you go a little bit deeper into some of the questions you might want to ask that provider? If you are diagnosed with oral GVHD, do you need to change providers?
Yeah, these are really, really great questions. And this is tough to navigate, right? Because not everybody lives close to a major medical center that has a dental clinic. Okay, so I'm going to address first, how do you know if your community dental provider is, good? A good indication of that is if you are at a dental office where you're able to see the same provider sort of every time, if you have like a dedicated dentist who sees you in that office. A lot of times this will happen in more sort of privately owned offices versus these corporate clinics. If you're able to actually have a relationship with that provider, maybe they actually know your name, which is great, which is what we want to happen. And they're able to spend, more than 30 seconds taking a look when you are there. There are dental specialists that are a little bit more well-versed in some of these issues. So there is a dental specialty called oral medicine. And there are some, I think the American Academy of Oral Medicine has a provider directory where you can put in your address and see if there's anybody sort of in your local area. Unfortunately, there are also not a lot of these providers sort of out in community clinics. A really wonderful tool that the BMT InfoNet has developed is a provider directory. So because you're all here, I'm guessing that you're relatively familiar with the resources from this great organization, but they have a provider directory where you can go in and enter your area and look for the specialists that you need. And these are all people that have sort of been vetted to have expertise, mostly in graft-versus-host disease, but of course in post-transplant care. So these are individuals who might be able to help you if you do get that diagnosis of graft-versus-host disease and want to see a provider. You will always need a regular community provider for your cleanings and your dental screenings and to take care of, a broken tooth if that comes up or any of these other sort of more run-of-the-mill dental problems.
Thank you. You gave some really good concrete recommendations for how to deal with dry mouth. There are other symptoms that people are experiencing in the chat, and I wonder if you can speak to them. So texture changes to saliva or overproduction of saliva. Are there recommendations that you have for those?
Okay, so these are great questions. I will tell you that we know that oftentimes after transplant, the character of saliva changes. We haven't been able to sort of really quantify that in the lab very well. I think it has something to do with like the mucins, like the sticky, thicker parts of your saliva aren't really made in the same way anymore. So whereas your saliva should be doing a really good job coating your mouth, again, kind of like that chapstick for the inside of your mouth, it just isn't working super well anymore. So in this case, if you feel like you have enough saliva, it's maybe enough to chew and swallow food without drinking water, but you still feel like your mouth is dry, this is pretty common. We actually see a disconnect between patients reporting that they have dry mouth and when we actually measure the amount of saliva that you can make, like spitting in a tube for 5 minutes. Oftentimes these things don't match up. So we know that your experience as a patient is not always the same as, what we can measure and put a number on in our clinics. So in this case, I would recommend some of these dry mouth products. They may be helpful. And in addition, just simply getting good nutrition and really supporting your body being able to regenerate and rebuild itself. The other question was overproduction of saliva, yeah? So
yes,
we have seen some saliva super producers come about when there's a lot of inflammation in the oral cavity. So there are people that can, give me a whole tube of saliva in 20 minutes, which is very unusual. And oftentimes they'll have a lot of inflammation in their mouth, but not always. So if this is the case, you can manage it probably the way you're already managing it, either, swallowing on a frequent basis or spitting. If you have a job that involves speaking, I had a wonderful patient who was a music teacher, and she really struggled because she needed to sing on a regular basis with her students. And this was a problem because she was making too much saliva. There are medications that are sort of the inverse of the ones that I talked about that can reduce your secretions. These are anticholinergic medications. I would not generally recommend them unless you were, in like a desperate, overly juicy situation, simply because it will impact every exocrine gland in your body. So it'll impact your tears and your saliva and other things. I would recommend trying to develop some strategies to just sort of, get rid of that saliva on a really regular basis, whether you're spitting it out or whether you're swallowing it. And I hope that it's not a permanent situation. You can see a provider. There are things they can do with salivary glands to sort of reduce the amount of saliva that they're producing. Again, nobody would be very enthusiastic about doing that because we want to make sure that you've got enough juice to function on a daily basis.
Thank you. We have a few folks in the questions in the chat who are experiencing loose teeth or bone changes to their jaw, to their teeth. And what would you recommend for them to help prevent that from getting worse or manage loose teeth overall?
Yeah, these are great questions. We do see sometimes when patients have been on high-dose prednisone, sometimes you'll get a shrinkage of your gums, less so your bone, but sometimes that shrinkage of your gum tissues will loosen the teeth a little bit, right? Because they're not doing their job anymore. Sometimes that improves after you're off those prednisone pulses, and sometimes it does not. So in that case, if your teeth are loosening, 1, see your dentist. 2, tell them, about the loose tooth situation. There are things that can be done. So if things are really loosening, something that might be done is placement of a permanent retainer on the back of your teeth, on like a sort of flexible retainer that's bonded to the back of your teeth to help sort of stabilize everything so that you can get some healing around those teeth and have them ideally tighten up a little bit. And of course, you want to make sure that it's not because of periodontal disease or another inflammatory condition that can be managed by either your community dentist or by a dental specialist like a periodontist, where they'll do sort of deep cleanings and make sure that they're getting that bacterial biofilm, hopefully to a healthier state on your roots of your teeth.
Thank you. We also have 3 questions in the chat about, your talk is about both GVHD management, oral GVHD management, and also oral health that is not GVHD. And so while GVHD comes from people who've had allogeneic cells from a donor, we have some questions in the chat about, are there any known oral issues that happen after autologous transplant or after CAR T therapy?
Oh, these are great questions. Generally, the question is if we see signs like conditions similar to GVHD that happen either after auto transplant or CAR T cell therapy.
Correct.
Okay, great. I just needed to confirm I'm answering the right question. So generally, I full disclosure, I do not see very many auto transplant patients. Typically, any of these side effects can be seen in auto transplant patients if you had some of the same types of conditioning. So chemotherapy, radiation, to get your body ready for that auto transplant of your own cells. Your cells won't be, attacking your tissues but you certainly can have side effects longer term from chemotherapy. So things like taste changes, something that we would expect from radiation would be fibrosis within the tissues, or sort of tightening up of those tissues, either around the oral cavity or potentially in your joints, and possibly also dry mouth. So this is one of the reasons that we will often take a small lip biopsy in the setting of dry mouth, because there are so many things that can cause it. CAR T cells are sort of a different beast, simply because there are so many different flavors of CAR T cell therapies out there. Some of what you're experiencing could indeed be because of the conditioning prior to your CAR T cell regimen. And some of it could be due to side effects because of the specific target of your CAR T cell, or off-target effects from that CAR T cell therapy. And without knowing exactly, which therapy you got and what those targets were, it's difficult to say exactly what the situation could be. Next question. I see we've got 5 minutes left.
Yes. So this one might take a couple of minutes, so I will consider this our last question, because we've had this come up in a few different ways and phrasing in the chat. And it's really a question about self-advocacy and how to know what to ask for. We have a few comments in the chat that say, well, thank you for the presentation, but that doctors have not pointed out that these are things that that folks should be looking for in their own oral health, and specifically with the pictures that you showed. But also a few people who are experiencing some of these symptoms that you describe and that you've shown in the pictures, but that their providers are telling them not to worry about that. And so can you help folks understand what they should do if they think that they have an issue and they're feeling an issue and a symptom, but they don't know where to turn?
Oh my gosh, that is like $1 million question right there. I hope that you are with a transplant team that will listen to you and listen to your symptoms. Sometimes the philosophy at different transplant centers is that if something isn't painful, it doesn't need to be treated, right? So if you see some of these white lacy lesions in your mouth, but you're not having any symptoms, that it's not something that needs to be treated. And indeed, it might be something that, comes, it stays for a few months, and then it will go away on its own. But especially if you are experiencing symptoms, or if you feel like you've got mouth changes happening, please just continue to point this out to your providers. At our specific medical center, I would have more specific advice of, how to navigate this. It's hard to know because every medical center is set up a little bit differently, and everyone's post-transplant care is set up a little bit differently. But you are your best advocate, and you know your body, better than anybody else. It might help to have a caregiver help to advocate for you. Sometimes they can, make some contacts that might be difficult to do on your own, because you are managing so many things all at once after transplant, especially if you have medical complications. So this would be my advice. Be persistent. Have faith in your ability to know your own body, and maybe get somebody to help advocate for you. When they're making those appointments, to say to the schedule, or the nurse or the patient care coordinator, like, hey, we've got mouth changes. Is there a dentist I can see? Like, is there an NP who's really good with mouth stuff? Oftentimes dermatologists also are able to recognize and treat oral mucosal conditions. So that might be an option. Different people are more and less comfortable with looking in the mouth than others. But it is a continuation of the skin. So I consider that a fair game question to ask your dermatologist. And then because I'm reading this question in the chat about the overproduction of saliva, and I saw the other symptoms, I would recommend considering some sort of neuropathy that might be involved. So we know that nerve damage can happen. either as a result of conditioning, medication, a lot of different things post-transplant. But neuropathy is definitely a component of graft-versus-host disease and post-transplant complications. So this is also something in your mouth. We know that nerves control the production of saliva, and they also control the movement of your tongue and some of these other things. So this is something to consider with your medical team.
Thank you so much. We are at time, and that is a beautiful place to stop. On behalf of BMT InfoNet and all of our partners, I want to thank Dr. Mays for her very helpful presentation and her answers. And thank you to the audience for being here with us on a Sunday and for your excellent questions. Before you leave, please stay online for just a couple of moments to complete a brief survey. Your feedback and your voice are very important to us. Thank you so much.